Good afternoon, everybody. Kelly McDevitt. We'll get our webinar started here in just a few minutes. I'll let everybody get logged in and join. All right, everybody, we're going to go ahead and get started. I am Kelly McDevitt, president of IBI. Welcome to our webinar today on shining a spotlight on virtual care use in the workplace. We embarked on this research over a year ago now, when it was very clear that the pandemic was causing quite a rise in the use of both tele and virtual care. As you all know, our utilization of virtual care was not what we all expected and wanted pre-pandemic, but obviously when the pandemic hit and folks weren't able to get out to their providers, we sought care through virtual means or through telehealth means. And we really wanted to study, what the effect of that was, both on from a productivity perspective, but also really how that worked out from an outcomes perspective. We got our research questions together from a research committee made up of our membership and asked what questions they wanted answered. And really, I think what we tried to focus on was what were the results of people using virtual care. And we partnered, something different this time in a research project for us, we partnered with our friends at UnitedHealthcare to not only support the research that we did, but to see how it really played out. Our research answers played out in the claims data. And so you'll have a little bit of a different view today here than our normal just research projects. So I want you all to keep in mind that as we thought through the research and the claims data, we really wanted to center on how to help employers make decisions going forward. And so, most employers mid-market to national account space have had national virtual care solutions in place for quite some many years now. And to help figure out how we morph that into our future, into our new normal, and what those solutions look like, what the products and programs that they offer look like going forward, and how as employees, they can best utilize those services to either fill gaps in network or to keep people at work, productive at work. Those are some of the questions that we were thinking in our minds as we were doing the research and looking at the claims data. So without further ado, I'm going to introduce Dr. Nicole Nicksic, who is our lead researcher on this project. And she's going to kick off the day with what the research was about, what we discovered in the research, and then turn it over to Dorris from UnitedHealthcare, who can kind of fill in the blanks with the claims data. So I'll turn it over to Nikki.
Great, thanks, Kelly. As Kelly mentioned, I'm the lead researcher here at IBI, and I led the research portion of this project. So just a quick agenda of what we're going to go through. I'm going to give you a very, very brief background, go over the research questions that kind of led this analysis. I'll be giving the results for the national data for 2020 and 2021. May will take over and give you guys results from UnitedHealthcare claims, and then Kelly will come back in at the end and lead a discussion on employer insights. And of course, we'll have time at the end for Q&A, and you can always pop them into the chat box as well. So as Kelly was kind of mentioning before about how our members kind of vote for our projects for the year and what's important to them, this was the virtual care was the second highest concern, right behind mental health, which we did last year. And so, this was a concern because obviously during the pandemic, during lockdown, we were seeing this dramatic increase of people using virtual care. And so kind of wanted to see how this increase remained throughout the year and how people were kind of receiving that. Was virtual care kind of closing this gap of in-person visits? Were people that needed care still receiving it? And just kind of differences and disparities in receiving and providing treatment as well. So we wanted to kind of expand from national data and get kind of a claims background to really kind of see how use is spanning the pandemic and what that kind of looks like for employees. So just, again, kind of using national data to see who is using it, what these people kind of look like, are there differences in demographics and health conditions, and then kind of following that up with the claims data to look at what people are, what subscribers are using, what providers they're using. And again, are there differences in their care and in their demographics as well as their subscriber profiles? So just in this first data set that I used from 2020, went from July to December. We used the National Health Interview Survey, something that we've used in several research projects in previous years. So this one's collected by the CDC online, and we had about just over 8,500 employed adults. And when we look at that, about 28% of those had used virtual appointment in the past 12 months, but we were able to kind of focus in with this particular data set for those that were already seeking care. So we wanted to know about those who saw a doctor within the past year, and within that subset, what their virtual care looked like. So 4 in 5 employees did visit a doctor in the last year from when they took the survey in 2020. And from that, about 1 in 3 employees, 34.2%, had used virtual care, and we weren't seeing a change in that. That was consistent from July to December, just over a third. And then when we're looking at, their self-reported urgent care and ER visits, we're seeing that increases across the number of times that they're actually using it. So we're seeing under average for virtual care use for not visiting urgent care or the ER, but then we're seeing this really high increase in virtual care use when people are using urgent care 3 times or more, when they're using ER 1 or even 2 or more times. And so it can kind of go on the assumption here that people are, potentially using urgent care or using virtual care first, and then being told that they need to actually see somebody in person. And so what does it look like with virtual care when we're actually missing work? So missing work due to illness, injury, or disability, the vast majority, nearly 60% of employees were saying that they weren't missing any work within the last year, and they were using virtual care the least. Of course, that's, the healthiest group there. But then we're seeing a consistent increase in virtual care use as you're missing more days of work as well. So looking at employees who have different health issues, who have self-reported impairment, so that's, difficulties with walking, seeing, hearing. We're also seeing they're using this using telehealth and virtual care more as well. So not only that, when they're missing work, they're also using virtual care more as well. But the kind of difference between these employees and just the general working population is that if you have a health issue or a self-reported impairment, you're also using virtual care more when you are missing days of work, and then more when you're missing a lot of work, 11 or more days, so into the 3-week territory due to illness. And that could be kind of said that people are potentially using virtual care so that they can continue to work. And then also when it's just, kind of on the extreme end of when they're sick for longer periods of time as well. It's kind of breaking down by different health conditions. So unfortunately, the survey doesn't break down exactly why you're using virtual care, what you're going for, but we can at least look at people who have different kinds of diagnoses if they're using virtual care at all. And not surprisingly, we're seeing it very high for depression and anxiety, as well as for if you had COVID, but we're also seeing it, fairly high for those that have diabetes as well. So breaking down conditions by missing work. Again, if you have diabetes or if you have depression, anxiety was similar, you're using virtual care more than if you were not diagnosed with these conditions at all. And with diabetes, we're seeing that people are using virtual care more when they're not missing work. Again, kind of on that assumption that they're using this kind of virtual care to continue to work and the convenience of that. But we're kind of seeing the opposite with depression and anxiety is very similar here. And we would expect this, that even with missing work, you're using that virtual care, as we know a lot of providers went to the use mental health services on an online platform as well. So just able to look at kind of different industries of who's using virtual care the most. And we're seeing public administration, education, followed closely by healthcare. At the top of that list and at the bottom, we're seeing retail, wholesale, manufacturing. And then going into different kinds of occupations, education, business, financial, again, healthcare at the top here. And then again, at the bottom, we're seeing sales, production, food prep, and food serving. Different occupations are using healthcare or virtual care the least, excuse me. And kind of looking at different access by location. I just posted a blog about the importance of access and different things you can do to potentially increase access within the employee population. But overall, the table, not surprising, we're seeing use highest in urban big city areas, and that decreases as we go expand into rural populations. The South has the most population in the country, but they're using virtual care the least. And then in all of the different regions here, we're seeing, besides the Northeast, we're seeing that decrease from a statistical standpoint. We're seeing that decrease from cities, again, urban, moving out, except in the Northeast. My prediction on that is just things are, more denser. It's a smaller land area. So although we're seeing the decrease, it's not in a significant way. And then brushing on different demographics here, where I'm kind of focusing and targeting on people that use it the least. And we're looking at males that are younger, less educated, identify as Black, have low income, also those that were never married, no health insurance, things like that. We did not see differences in how many kids you had at home, and that we can say is probably likely due to these are employees that are already seeking care, so it's probably evenly split through no matter how many kids you have, because you're already in that kind of sense. So these kind of come back when we look at 2021 data next. So we use the 2021 Household Pulse Survey. It's also what we use for our mental health data, and it is collected by the US Census Bureau. And we looked at April through October of 2021, separate weeks on that, and had over 350,000 employed adults in the past 7 days. So here we're looking at the total adult employed population here. So we're looking at just those who use virtual care at all in the past 4 weeks from when they were surveyed, regardless if they were healthcare seekers or not. So we're seeing here 1 in 5 employed adults were using virtual care during this time, but we're seeing a significant decrease after the July 4th holidays, actually. And they also asked a question about what you used more, and we're seeing that virtual, video use was more popular than using the phone. They also asked about their children's use. Not surprising, it mirrors what the adults did themselves. And again, we're seeing that decrease that we didn't have in 2020, but now we're seeing it in the summer of 2021 here after that 4th of July holiday. But although this decrease is happening, slight decrease in virtual care that we're seeing here, we're seeing a big increase in children not getting preventive checkups during the same time as well. So when we're looking at employees that are working outside of the home and looking at their virtual care here, not surprising, we're seeing high virtual care use amongst those in healthcare services, nursing home and hospital workers and things like that. And then again, at the end, at the bottom of this, we're seeing like the manufacturing, we're seeing food and beverage, other people that don't identify in these other groups as well. And just to note here that most employees did work in the private sector, like over 60%, but they use virtual care less than people that worked in public sector or worked at home, of course. So when we're looking at telehealth use when it comes to different health status, to disability, those that seek out healthcare more, these are all people that are using telehealth more. So we didn't get the nice different ranges of different health conditions like we had in the other survey, but those at least that had diagnosed with COVID, received the COVID-19 vaccine, those that were delaying their care eventually used telehealth virtual care. We're also seeing those that were on Medicare for disability were using telehealth more. That's self-reported impairment. And then also if you had seen a provider or went to the dentist in person, we're also seeing that you're using virtual care. Again, that's probably the people that are higher activators that are going to be using healthcare and different modes as well. So again, location, we had some state data, so we're able to make this nice map here. And again, showing, Midwest and South use the least, and then we're seeing these darker states with higher use on the East Coast as well as the West Coast. And again, just demographic profile aligns a lot with 2020. We're seeing those males that are younger with lower education, that weren't married, are using virtual care less. And then also here though, we're seeing difference for how many kids you have. And these again are the full adult population. Not all of these people are natural health seekers or have seen, a doctor for any reason within last year. So with 0 kids and 2 kids, you're using it less. And I can't speak from experience. Told you're using it more when you have 1 kid with the freak out, and then you're on when you have 2 kids, it's not as much. So we're seeing a little bit different profile here for that part. But again, the males, the younger, less educated are using the virtual care a little bit less. So that wraps up my portion. I'm going to hand control over to May to run through her slides on the claims data.
Before we do that, Nikki, I just want to jump in and kind of do another level set here about the research. So when we went into this research project, as I said, we tried to think about what employers, when they would have to evaluate their current tele or virtual health programs, what would they need to know? What would they want to look at? What data would they need to be successful? And thinking about one of the things that Nicole touched on, we're still in this state of delayed or avoided care. So until it comes back fully, we have people who are not being diagnosed, and we have people who are not being treated that are already ill. So think about 18 months from now when employers are dealing with possibly a particularly high trend that we haven't seen in many years, and they have to look back upon their programs and choose what's working, what's not, what we all have to go through, right? To figure out ROI or BOI for the programs you already have in place. We went back to our employers and asked them, why did you put in telehealth or virtual care in the first place? What challenges were you trying to solve for? And overwhelmingly, the answers were the same. Number one, it was the shiny new object, right? It was an exciting thing years ago to be able to have virtual care available for patients. We hope that it would keep people at work more often, increase productivity and presenteeism, or decrease absenteeism at least. Some were looking to fill gaps in networks. So what was an interesting fact about what Nikki just presented was we are seeing that part is not working, right? So where rural network gaps may occur, or people have to travel a fair distance to be able to get to care in person, we are not finding those people using virtual care. The other thing that's interesting is within the age groups that Nikki was talking about. I think people make an assumption that younger folks are going to use virtual care because they like to use their phones and for convenience. And that is another issue that most employers were trying to solve for: employee convenience. And years ago, when we first rolled out telehealth solutions, we made the co-pays or the co-insurance a little lower than in-person care. So these are the things that we wanted to look at to help our employers make decisions going forward as they weigh the solutions they have in place today. So now May is going to talk to us about how the claims data supports the research that Nikki did and what we saw in the claims data play out from 2020 through 2021. All yours, May.
All right. Well, guys, thanks for having me. I took a look at our national account book of business and wanted to see, these trends in virtual care. And let's see if the controls work. We did test this. Just give me 1 second, guys. There we go. So we're talking about virtual visits in medical. We've got two kinds. We've got these virtual first providers, and then we've got, think virtual first is going to be your doctors on demand, Amwell, Teladoc. But then we have the traditional doctors. So the doctors that have brick and mortar locations that you can see there. But then when COVID hit, now you can also see them virtually. So they're two very distinct kind of virtual visits. And we'll get into both of them because they have, very different patterns of utilization. And if you can see here with COVID, people are back in the office right now. They're going back. Most of the meetings, our visits are in person. I'd say about getting up there about 90%. And of the virtual visits, the majority, 90% of those virtual visits are with a traditional provider. So while those virtual first providers did see tremendous growth with COVID, it was far outpaced by the growth in the virtual visits by those traditional providers. So and you can see here, it is kind of leveled off, the virtual visits. So when we're looking at our national account, and I just looked at it updated, we're seeing about 89% of visits are in person. And then this mix with our virtual provider mix has been pretty stable on medical visits, okay? And so we're seeing that it's kind of stabilized. There is some variation, but overall post-COVID, the pandemic start, it's kind of tapered off. If we throw in though, behavioral health, that's a very different scene there. Behavioral health, we're seeing almost over 2/3 of visits for behavioral health are now virtual, and it's stayed virtual. So that has stabilized at a much higher level than medical. And that makes sense, given the reasons and the types of visit. So we're seeing that remain high, those virtual visits for behavioral health. But, for the most part, we're looking at, routine care and sickness for these virtual medical visits. All right. So again, we're going to look at our virtual providers. So these are the ones you call up, you generally just request any doctor, the first that comes available. We're looking at it from September of 20 all the way through August of 21. Right. A lot of data here. What I want to point out to you is that we're really focused on those first two columns. So had members that used a virtual provider, and then members that had claims, but no virtual provider visits. So let's compare those two. And demographically, they're pretty similar. The retrospective risk score is going to be their disease burden, pretty similar. Their activation, which is our measure of decision making, the members that use virtual providers tend to have a higher score there. And they're just really good at using all their resources. And that'll kind of be one of the themes of these members, is that they're high utilizers. They know their benefits, they know what they have available, they know how to use them. Okay. Taking a look at the paid or allowed amounts, let's look at the non-catastrophic. If you've got a catastrophic member, virtual provider, probably not a good idea. So let's look at these non-catastrophic. You can see spend-wise, the virtual provider utilizers are actually a little bit lower, okay? If we go down, the one that really jumps out though is that ER utilization. Look at that, 259 visits per 1,000 for members that used a virtual provider versus 179 for those that didn't. You can also see that the allowed amount per visit, which is directionally correlates with how serious was this ER visit, is a little bit lower. Those urgent care visits, really high. We're seeing those much higher, over 50% higher for those members that utilize a virtual provider. These are your high utilizers. These are members, if they're on the fence, they're going to go to the doctor. And we'll get into more about who they are and what else we see in their data. So why are they going? That's a big one. You can see that injury and poisoning, they're more likely to go, but it's not a huge gap. But then you get into all the other potential areas for why they're going, and you can see that they're far more likely to go. So, those respiratory conditions, we've got some folks on the end that will have a sinus infection for several months and never go. And then you have somebody who is watching the clock and they're like, no, it's been 10 days, I can go see the doctor now. And so these members that utilize the virtual visits tend to be the ones that are, more likely to go. On those visits, they're going to be there. And the same for urgent care. They're going to be more likely to go in. They're going to see those. When we're looking at who these members are, looking at the percentage of people in different age groups that are using it, those females aged 26 to 39, or even up to 49 were the big utilizers, with almost 7%, which is the highest. Men are much less likely to use it. And you can see that kind of distribution at the upper end and lower end of people wanting to use it. Overall, about almost 3% of members, though, had a virtual visit. Trying to watch my time here. We did a geographic analysis. This is based on the members' state of residence. So that Vegas, the Nevada you see out there, it's not weekends gone wrong. That's members that live in Nevada. So they had the highest utilization. And then members in Rhode Island had the lowest. What we're seeing, though, is the rural members far less likely to have a visit with a virtual provider. And that's either the virtual first providers or the traditional providers compared to the urban members. So, one of the things we talk about there is the access. And we're able to look at the FCC data for broadband access, and it lines up almost exactly. Members with access to high-speed internet were much more likely to access a virtual provider. And that makes sense. So those two are very strongly correlated. So you kind of can't talk with one issue without talking about the others. We did looks by income. We found that, there are, on our end, the lower household incomes tend to have a little bit higher utilization. And they also have higher ER utilization, but that's kind of, if you see it, it's kind of stable for both, that those ER utilization tends to decrease with an increase in income. And that was pretty, stayed the same with both the utilizers of virtual visits and non. Okay. We also did a look by ethnicity, and this is inferred data that we get. And you can see that the Hispanic utilization for virtual providers was really solid. It was over 3%. And if you go over to the other chart with our ER visits, so that's, how many ER visits, are they going? You can see that their ER utilization is also on the high side for both utilizers of virtual visits and members that did not utilize those virtual visits. Same for African Americans. Those are both high utilizers. So what we're trying to figure out is those virtual providers, is that impacting their ER utilization? And what we're finding is that same pattern of members that use a virtual provider, much more likely to go to the ER. That's staying true throughout all these different views that we've been looking at. And then let's look at like, why are people going? So on the left, we've got the broad categories, and you can see respiratory. That's going to be the big one. That makes sense. Genitourinary, it's going to be your UTIs. We're going to see, rashes, things like that. Those are making up the bulk of those, and everything else is, kind of a catch-all. But if we look at those top 10 diagnoses, so if we narrow it down, we're looking at the actual diagnosis, you can see that, numbers 1 and 5 are going to be UTI related. And then we've got 2, 3, 6, 7, and 8 are respiratory, cough, cold, that kind of, reasons for going to a virtual provider, which makes sense. These are the kind of things you would see a virtual provider for. It's not ongoing care. You need to see somebody. So now COVID was actually pretty low down on the list. And part of that is the testing. So you can't get tested virtually. So I think a lot of those virtual visits for COVID just didn't make sense. People were much more likely to utilize an urgent care or in-person provider just so that they could get that testing done. So they didn't want to do 2 visits. They just went ahead and did that 1 visit. All right, so that's our virtual visit. We're going to spend just a brief amount of time talking about the virtual visits with the traditional providers. So for here, we looked at our subscribers that utilized the traditional virtual visit, and then also how they stacked up to those that used the virtual first providers, those national providers. So, 25% of members used a virtual provider, 20% with that traditional provider. And then, we talked about that 3% with the virtual provider for subscribers. Demographically, the members that use the traditional provider tend to be a little older. And then if you go looking at that subscriber risk score, that's that disease burden. You can see that the members that utilize the traditional providers' virtual visits have a much higher disease burden. And because that is just why they were using it. It wasn't a one-off sinus infection that they're seeing their provider virtually for. It was more likely to be ongoing disease management. So we are seeing that play out in their disease burden and on their utilization. You can see their activation, they do pretty well. They make good decisions, but those people that do those virtual providers, they're the ones that are all over it and have the best decision-making scores. ER visits, okay? Now you can see that the people that are using those traditional providers, to see them virtually, they had 263 ER visits per 1,000. We're looking at subscribers only. That's much higher. But again, they had that higher disease burden. So if you look at the green line, that's the allowed amount per visit. And that's kind of directionally shows you how serious that visit was. So you can see that for the members that use the traditional provider virtually, they have the highest allowed amount per visit. So this tends to be for more serious things. Whereas members that use the virtual provider, they had the lowest allowed amount per visit, which suggests that it was for less serious. Okay, so just a little bit of difference. They did have that high, but are they utilizing it appropriately? It looks like so. Okay. We want to take a little deeper dive into just a condition, because this is what a lot of those virtual visits with the traditional provider were for. It was for managing like something like diabetes. And again, if we're going to look at that retrospective risk score, so that's that disease burden. The members who are seeing a traditional provider virtually have a much higher disease burden. These people are sicker, they need more care, and virtual care with the traditional provider has just been a way for them to access that care. So they do have higher cost, but again, it's that higher risk profile. What was interesting to see is that even with their higher risk, Their ER visits per 1,000 were below the members that use the virtual provider, suggesting that the traditional providers are doing a good job managing that condition. Again, they had high utilization for urgent care, but still lower than those traditional providers, or virtual providers, excuse me. And just looking here at their decision-making, we've got the diabetics with no virtual cares, that's the dark blue. And then the ones that access the traditional provider, those are the two in the middle, the lighter blue, and then the virtual providers in the yellow. And you can see there's not huge discrepancies in this, but on a lot of these metrics, the prevention, the engagement, resource use, well-being, the members that utilize the traditional providers have better decision-making and scores in there. Site of care, that a lot of things play into that. I wouldn't, read too much into that. And if we look at like diabetic specific measures, what are we measuring here? It's kind of a mixed bag there, but overall they tend to do a good job of getting those screenings, getting that provider visit, taking their medication, getting those exams. Not as big of a difference there, but still good scores overall. Right, and I see my cat has made an appearance. But I think I'll now pass it back to Kelly and Nicole for questions.
Thanks, May. So we do have some questions coming in, but before we get there, I just wanted to kind of go through with you all. If May, could you advance the slides to my slide real quick while you still have control, please? We talked about.
I apologize.
No, that's fine. Right there is great. We talked about why we did this project and what we learned, and I think that some of the things that Nikki and May have gone through were no-brainers. It was a pandemic, so in the early days, in 2020 at least, if you called a virtual care provider and you had symptoms of COVID, chances are they were sending you to an urgent care or an ER, right? So the numbers that May presented in that data, keep in mind the time period that we're looking at. So when people sought care, whether it was from their traditional provider or from a virtual care vendor provider, the result oftentimes, if they were talking about COVID symptoms, were probably the same. They were sent either to their own doctor, to an urgent care, or to the ER. I think and we did get a question on this, what's going to be important going forward is measuring now that we're in sort of a post-pandemic world, let's say working our way back to normal. Now we measure those results. Does the cost of medical care on the whole go down when virtual care utilization goes up? And so are we actually, avoiding more costly care by using virtual care in its place? We looked at things like that during the research, and we could probably correlate some answers there, but knowing that care was already so suppressed, people weren't getting care for chronic conditions, for preventive care, et cetera, and even for much needed care like cancer care or surgeries, it's hard to say for those who used virtual care, did their traditional medical costs go down because all care was down? And so those are interesting questions, but I think ones that we will have to measure going forward. So real quick, just to wrap up, when we did this research, we always at IBI go out and ask our employers for insights on these topics. Some of these things we've already touched on, larger employers, mid-market to national account size employers, integrated national health vendors as part of their benefit plans and strategy way before the pandemic came. Reasons, convenience, cost savings to the employee, especially if the copay or the coinsurance was lower, and then the hope of less missed work time. Access was also an issue for some employers, where they think that they don't have access, particularly in rural areas or low-income areas. People might utilize virtual care. Unfortunately, our research did not find that necessarily to be true. But that, as May indicated, could also be affected by outside influences, such as, do they have broadband, or do they have a smartphone? Do they have the technology needed in order to actually use the product and program that's available to them? Looking at how your members are utilizing virtual care is really important. And you all, from this particular project, hopefully saw some data that you would need to study to know the answers to these questions. As Nikki said at the beginning of the meeting, we will have this deck available to you after the webinar. So you will be able to see some of the data points that you might want to measure in your own population to help you figure out, are my employees using traditional providers who have stood up a virtual care option, and will they continue to do so? Are they using the national vendors? What does your correlating urgent and ER usage look like? And then really, of course, always focus on outcomes. What was the outcome of those visits? And are they now using virtual care on an ongoing basis for things like traditional disease management care? Communications were extremely important to all of our employers that we spoke to. Some employers got very creative, doing magnets, postcards, using QR scanning codes to send to employees to let them know that their virtual care was available to them. I think in this research, we really separated mental health over here, because that virtual care was solving a completely different problem. And then, virtual medical care over here, because they study very differently. And so when you look at how to communicate these programs, you may want to look at communicating the virtual care for mental health and the products and programs you have available there very differently than you look at the virtual care for your medical diagnoses. All employers said the same thing. These communications have to be focused, concise, intentional, and constant. So, I don't have to tell you all, communicating often and very concisely is what you need to do with your employees to let them know that they have these things available to them. Expanding virtual care into new well-being programs is something that a lot of employers are looking at now. And that's why we advise to really look at the data about the programs you have in place already before you branch off into some of the new virtual care options for physical, emotional, financial, social, workplace. You would be, I think it's ill-advised to branch off into more virtual care until you actually know how your population is behaving today with the solutions that they have in place. There is no doubt there's any number of these solutions out there in the market. Obviously, you all know how to go through an RFI or an RFP process in which you select the best vendor. Looking at holistic solutions that are helping with attraction and retention of new employees and existing employees is very important to employers right now. So they're looking at these solutions as a way to sort of put their arms around their employees and help them to be healthier and happier at work. So I do see we have a bunch of questions, and so I'm going to save the last 15 minutes for May and Nikki's questions. So the first one I kind of already touched on, and that was, do medical costs go down as a result of virtual visits? I'm going to let May answer this, but I will say that I think it would be very hard for us to correlate that, at least during 2020 and 2021, because medical costs were down overall. But May, do you have a thought on that one?
It's just very hard to say. And of course, you've got the two different types of virtual visits. See another question there, does virtual visits cause visits that wouldn't have been visits? And we think understandably, yes. If it's Saturday and you're not feeling well, but you don't have to get off the couch, okay. So you see where this is going. From a cost standpoint though, you have to look at the cost of a virtual visit, which is around $50. And then we look at the cost of an ER visit, which is $2,500. So you've got 50 virtual visits for one ER visit, or 5 or 6 urgent care visits. And again, we talked about these people are high utilizers. So we don't have any data to, prove this, but my gut is that these people would seek care elsewhere, probably. So this is another good avenue for them to access care. Does it save money? It's unclear.
Yeah,
I don't think it's dramatic either way.
Yeah, I think I agree. This is one of those things going forward and really going back to before 2020. You can look at your virtual care utilization and medical costs correlated for those individuals who used it before the pandemic. During the pandemic, it's much harder because there were so many other outside pressures from the pandemic itself that affected costs and obviously utilization during that time. So to say somebody had a virtual care visit and they wouldn't have had a medical visit, or the opposite, that they had a virtual care visit which caused more visits, right? It's really hard to measure that in the pandemic world when we're in a situation where people could not be seen in person. And so much care was directed to urgent and ER care, whether you saw your own provider or a virtual care vendor or national vendor. I will say that some employers, as they're thinking about their go forward strategy, are talking about whether or not their strategy includes driving care back into what is, oftentimes referred to as a medical home model or PCP selection, et cetera. So if a person has a relationship with a doctor, do you prefer that they see them, whether it's virtual or in person? And then really sub-bucketing those folks into those who are healthy and need preventive care versus those who have a medical diagnosis or comorbidities or complex care. Where would you like to drive that utilization, whether it be virtual or in person? It should be part of an employer strategy. And really, as I talk to my employer friends, I feel like we're getting back into years ago segmentation. This is all about knowing your population, not only their preferences, which we're all very concerned about right now, but how they utilize care and how they prefer to utilize care. And then also which care would affect the best outcomes for those different populations. The next question is, and again, probably May, this is going to be for you. Did you look at any data, and I don't think we did, on utilization when virtual care was free or discounted from a full copay? I don't know if we had that plan design information to look at.
Yeah, we didn't look at that. And again, that's going to be that COVID noise because a lot of the people moved it for free because of COVID. So right. It'd be hard to track what was driving that utilization, if it was cost or not. I mean, generally cost does help, but sure. We don't have any clear data just given the COVID noise.
Let me ask this. Could you at least look at utilization between those that had zero copay versus something other than zero copay?
We could.
Okay.
Yeah.
It might be interesting to see if, cost was a big driver for folks. If they did choose to use virtual care, those who have a $50 copay for virtual care versus those who had a zero copay for virtual care, if that really affected utilization in any way. Okay.
I think we do see slightly higher utilization on the high deductible health plans. So, members do have a little bit higher utilization, but again, those tend to be younger, more tech savvy members that are just, more knowledgeable about their plans. That's why they're on a high deductible health plan. So we can, though, take a look at that.
Yeah. And then the next question, did virtual care providers integrate or share their data on visits with the employer's health plan or employer's worksite clinics if there was one available? I think that really, and May, you can weigh in here as well, but that really depends on the virtual care provider, one, and the employer, right? So the employer typically would be requesting who that data is shared with. Typically, at least the large national vendors can very easily plug and play their data into either a data warehouse, a health plan to be used for things like disease management programs and wellness programs. But that's really typically, at least in the self-insured environment, up to the employer and the abilities of the virtual care provider. May, do you have anything to add?
I'd say in large part, the virtual care those virtual first providers, those claims do run through us. And so we can see everything we can normally see. With the on-site clinics, though, that's a very per employer basis about what is able to get shared. So sometimes that picture can be incomplete.
Yeah, and I will say the same about at least the early adopters in the non-national vendor world. So for our traditional providers, mom and pop providers that are not necessarily hospital owned or large practices who had to stand up a virtual care solution very quickly, and some kind of clunky, the exchange of data through a traditional provider at first during the pandemic may have actually been less than with the national providers because they had been doing those things for years in the virtual world. They probably caught up very quickly because at least the data is in the chart, but the data exchange of something other than the encounter, meaning I'm billing a virtual care visit, may have been a little clunky at the very beginning. I think most of that is worked out by now. Do you agree, May?
Yeah, it took some doing, a lot of behind the scenes, but yeah, I think it's pretty worked out by now.
Okay, fantastic.
A lot of IT guys had a lot of late nights.
Yes, I'm sure. And and not for nothing, traditional doctors' offices weren't necessarily set up to take on this type of a role. They don't have IT departments typically. So, okay. Next question. Since virtual care utilization appears lower in the rural areas, do you have any data comparing the availability or number of in-person providers in urban versus rural settings, or physician to patient ratio in urban versus rural settings? Curious about whether rural utilization is lower due to lack of internet access, or because in-person provider visits are more readily available in a smaller population. Okay, that's a lot to unpack. So May talked about and presented, it's in the deck, the lack of internet access. So that's very clear. In rural areas, utilization is lower, and we believe there's a direct correlation between them having access to high-speed internet. And then curious about whether rural utilization is lower due to lack of internet, yes, or because in-person provider visits are more readily available in a smaller population. So two things. Your first question is, can you see what the availability is of a provider in a either urban, rural, or suburban? The answer is yes. Any healthcare provider, any of the large carriers can do a network access report and tell you what in-person providers are available. I think many are now also looking at not only in-person availability for those traditional providers, but virtual availability for those traditional providers. So you can look at that, and an employer can have those reports run very readily by their medical carrier. That's a function of the network access folks within that business. I don't think the last part of the question, is it because of in-person provider visits are more readily available? Typically that is not the case in rural areas. So we would see, if you overlaid network access in rural areas with providers and national virtual care providers, you would see that, virtual care is much more readily available in rural areas. Readily available, but not necessarily, looking at May's data, accessible because of the internet issue.
Yeah.
Anything to add, May?
No, I think that tracks.
Yep.
From what we're seeing.
All righty. Next question. Did virtual care third-party providers prescribe more than traditional providers using virtual care? This is a really good question, and one that pre-pandemic, we typically do track as part of our ongoing sort of outcomes data. Are either virtual care at a traditional provider or through a vendor, what are the prescribing patterns, right, of that particular care? I think during the pandemic, again, it was sort of everything out the window at that point, because not only were folks there was no care to prescribe for, right? You had to be tested before you could get any type of care. And in 2020, there wasn't much available to you, certainly not by prescription. And second, this is one of those issues that sort of post-pandemic world, you should always be tracking with your virtual care visits as part of your data set. Are virtual visits causing more or less prescriptions to be written than a traditional provider? I know you had looked at accessing prescription drug data during your research.
So we looked at this prior to COVID on the fully insured block, because we have pharmacy data. You know, we need to be able to tie those together. So do virtual providers prescribe more antibiotics than the traditional? Slightly, yeah. Urgent cares also do, but then again, the more serious cases go to urgent care. So I think there was, you know, in the early days of virtual care, it was just like, you get antibiotics, you get antibiotics. And I think they've really reined that in and are being much more cautious about that. So they are elevated. I don't think it's, you know, terrible though, when you think about it. We looked at, you know, major things like, you know, UTIs, respiratory infections, those are really common things in order to compare those. And, you know, they're generally at or below where urgent care was pre-pandemic. So.
Right. Okay, I know we only have a couple of minutes left, so I will let you all have time for one more question in the Q&A before we wrap. Okay, well, I'm giving it a minute. I'm just going to sort of wrap up our thoughts here. I think that our purpose for doing this particular research and why our members asked for this research was to help employers figure out what now, right? So the pandemic obviously brought telehealth and virtual care to the forefront. Now we need to study how that played out in your population. And as you move forward, how you may or may not want to adjust your strategy and your products and programs accordingly for the future. So as we start thinking about, I think I've playfully named it the Great Reckoning instead of the Great Resignation, the Great Reckoning of this hush crush period that we are in. So we're still in this delayed care, avoided care mess that we've been in for 2 years now. When that starts to play out in your claims data in the form of, you know, much sicker people, undiagnosed population, high cost claimants, and as employers and their supplier partners, we have to look back on all the products and programs that we've been using these past 2 years and decide which ones we keep and which ones we don't. What data and insights will you need as an employer to make those decisions, to make good decisions going forward? So we hope that this information, both the research that Dr. Nicksic did and that May provided us in the claims data, can help you to see the type of information you will need to help you make those sound decisions going forward. As always, we thank you for joining us, and we hope this was very informative. The presentation and the recording will be available to you on our website for our members, and it will be sent out after the meeting. If you have any questions at all, don't hesitate to contact us through email. You can write to me or you can write to Dr. Nicksic, and we'll be happy to answer any questions that come up after the webinar. Thanks all for joining us. Have a good one.